Welcome to part 2 in our section on the nephron. In the last video, we discussed the different roles of the nephron, focusing on each segment. In this section, we will focus on how to apply that knowledge in various contexts, spending much of the time looking at the nephron as a whole. So let's get started. So let's first talk about the tubular filtrate concentration over plasma concentration. So this provides a ratio that is abbreviated TF divided by P. So of course those brackets indicate that concentration of solute is being evaluated, not the amount of solute. This is an important distinction, as you will see. So let's discuss the tubular fluid to plasma concentration ratio by drawing it out. So let's draw an image of the glomerulus. So this is the afferent arteriole, and then over here will be the efferent arteriole with the glomerulus. And I'm just going to draw one part of the Bowman space, and then we're going to draw the cells of the proximal convoluted tubule. And we'll write blood on this side, or P for plasma, and then on this side we'll write urine, or TF for tubular filtrate. So the first substance to understand about this topic is water. In the afferent arteriole here, the plasma contains water and other substances, notably sodium. So the glomerulus will freely filter the water and other substances, and because the glomerulus doesn't restrict plasma and its contents from entering the Bowman space, the tubular fluid is considered isotonic. So the tubular fluid here is isotonic, and that is compared to the plasma. So I'll write isotonic here. And we will discuss the tonicity of the tubular fluid later in this lecture. The point is that the concentration of water in the tubular fluid matches the concentration of water in the plasma. So the tubular fluid to plasma concentration ratio would be 1:1, or simply 1. If we were to graph this, as many of the Step 1 review books do, it would look like this. You'd have, on the y-axis, you'd have a tubular fluid to plasma concentration ratio, 0, 1, and 2, and the length along the proximal convoluted tubule would be on the x-axis. So we'll write PCT to represent the proximal convoluted tubule length. And as we discussed, the ratio for water would be equal to 1. And even though water is being reabsorbed throughout the length of the proximal convoluted tubule, it is being reabsorbed with solute. So the concentration of water in the tubular fluid will continue to match the concentration of the water in the plasma. And this is the case all across the PCT. So we'll draw a horizontal line to represent this. So that's water and its tubular fluid to plasma concentration ratio. So we'll just write H2O. The remainder of the substances that are reabsorbed by the proximal convoluted tubule are compared to this line, the reabsorption of water. They are either reabsorbed more quickly, so as to decrease the concentration of the substance in the tubular fluid, thus decreasing the ratio on the y-axis. Or they are reabsorbed more slowly, so as to increase the concentration of the substance in the tubular fluid, thus increasing the ratio on the y-axis. The substance may even be secreted by the proximal convoluted tubule and have a very high concentration in the tubular fluid, thus having a very high ratio on the y-axis. It's important to recognize that most of these substances are freely filtered by the glomerulus. So immediately upon leaving the glomerulus and entering the proximal convoluted tubule, which is indicated by this spot here, the tubular fluid concentration to plasma concentration ratio will be equal to 1. And this is the case for pretty much every solute you will encounter. However, as described previously, the substance can be reabsorbed quickly, slowly, or even be secreted. So the tubular fluid over plasma ratio will change by the time it reaches the end of the proximal convoluted tubule. Now that we have talked about water, let's apply this to the other solutes that are reabsorbed by the proximal convoluted tubule. Sodium, which is freely filtered by the glomerulus, is reabsorbed with water in a 1:1 ratio. So sodium is reabsorbed, and then water is reabsorbed in a 1:1 ratio. So its tubular fluid to plasma concentration ratio is similar to that of water. So on the graph, it would look just like water. In other words, equal to 1. And I will use a line to represent the sodium ratio. So it'll be really close to water here. And as discussed previously, potassium follows water and sodium. So write potassium here, and it follows. It, of course, is in the 1-to-1 ratio. So it will be depicted on the graph similarly, and I will use another purple line to represent potassium. So write potassium here. Of course, sodium. Now let's talk about glucose and amino acids. Recall that they are entirely reabsorbed in a normal patient. So by the end of the proximal convoluted tubule, they will be totally out of the filtrate. Glucose and amino acids. We'll just write AA for short. So they're totally reabsorbed in the proximal convoluted tubule. So here's a question. Where on the graph should we place the line depicting glucose and amino acids? Should it go here, here, or here? Well, if there is no glucose and amino acids in the tubular filtrate, then this concentration should decrease, thus decreasing the ratio to practically 0. So the line would actually look something like this. And this signifies that by the end of the proximal convoluted tubule, the glucose and amino acids have been completely reabsorbed. In other words, there is none left in the tubular filtrate. Now let's do a harder one, inulin. As you recall from the equations lecture, inulin is freely filtered and it is not reabsorbed and it is not secreted. So where on this graph should we depict the tubular fluid to plasma ratio for inulin? So to answer this, we need a new page. So I'm going to draw another depiction of the proximal tubule, and I'm going to divide this into sections. We're going to go early here, the middle here, and then finally late distal tubule. So we know that there was a lot of water early on. So we'll draw a lot of water. But gradually, it is reabsorbed with sodium. So there's less and less water. So by the end of the proximal convoluted tubule, only 35% of the water remains. And of course, we saw sodium was reabsorbed with water. So as you can see, we're having less and less sodium, but the concentration remains the same the entire time. So now let's look at inulin. I'm going to draw 3 green dots for inulin. Inulin was filtered by the glomerulus with water, but unlike water, inulin is not reabsorbed. So the amount of inulin in the nephron will remain the same, and as I will depict by these 3 dots. It does not change. So write tubular filtrate to plasma concentration. So if the amount of water is decreasing, but the amount of inulin is not, what is happening to the tubular filtrate concentration of inulin? Well, it's increasing. With such a high concentration of inulin, the tubular filtrate to plasma concentration ratio will be quite high. So let's demonstrate this on the graph we were just using. So we've got inulin that increases in concentration over time. So write inulin. So now let me draw a line above the line for inulin. Let's think, what can make a substance have a higher TF, tubular fluid, to plasma ratio than inulin? What can make that number go higher? So let's discuss this by looking at our other diagram. Recall that inulin is neither secreted or reabsorbed. So the only way for a solute to have a tubular filtrate concentration higher than inulin is if it was secreted into the urine from the proximal tubule. A substance that can do this is creatinine, as demonstrated by these 3 little red dots. So let's start with 3, and then as the urine progresses through the proximal tubule, more is secreted. So I'll draw 4 dots here, and then 5 dots here. And this represents the increasing concentration. So as you can see, the secretion of creatinine would cause its tubular fluid concentration to be even greater than inulin. But what if we had a substance that is secreted even more than creatinine, such as para-aminohupuric acid, or PAH? Well, PAH, I'll draw these little blue dots, draw 3 little blue dots for PAH. If they were totally secreted, they would have a very high concentration by the end of the proximal tubule. So let's plot this on the previous graph. So there's creatinine, and then PAH is totally secreted, so it will have an even higher tubular filtrate to plasma concentration ratio. So we'll draw it like that, PaH. The only things left to discuss are urea, chloride, and bicarb. Let's start with urea. Recall from the previous lecture that 65% of the water, potassium, and sodium is reabsorbed in the proximal tubule. And then 100% of glucose and amino acids is reabsorbed in the proximal tubule. Also recall that 50% of urea is reabsorbed, which is less than 65%. So urea will fall up here on a line that looks like this. All right, urea at 50%. Moving on to chloride, that will be reabsorbed with sodium at the same rate, but not in the early parts of the proximal tubule. So its curve will look more like this. So by the end of the tubule, it is being reabsorbed at the same rate as sodium and potassium and water. So now let's talk about bicarb. It's almost entirely reabsorbed by the proximal tubule, but not quite as much and not quite as fast as glucose and amino acids are. So bicarb will follow a curve more like this. It makes sense that the body would want to reabsorb most of the secreted bicarb so that it can maintain a normal serum pH. This graph that I have drawn here depicts figure 4.6 from your text. So let's go to that graph from your text and do some practice problems. So for the first question, let's say there's a patient with chronic respiratory acidosis. As discussed in the acid-base section of this nephrology chapter, the proximal convoluted tubule will compensate for the respiratory acidosis by reabsorbing more bicarb. Now, you don't need to be a master of acid-base physiology to answer this question. The point is simply that the proximal tubule is reabsorbing more bicarb and reabsorbing it at a faster rate. What then will happen to this line on the graph depicting bicarb? Well, if bicarb reabsorption has increased, then the tubular fluid concentration of bicarb would decrease. Therefore, the tubular fluid to plasma concentration ratio will decrease and move the bicarb line closer to that of amino acids and glucose on the graph. So let's do another question. Let's say that a patient has Fanconi syndrome. Just to review, Fanconi syndrome is a general defect in the reabsorptive ability of the proximal tubule. So nearly every solute will be less reabsorbed in the proximal tubule. If this is the case, which way will every line on this graph shift? Well, if everything was being reabsorbed less, that is to say, excreted more, then the tubular filtrate concentration would increase. Therefore, the tubular filtrate to plasma concentration ratio would increase, and that would shift every line up on this graph. Now let's do another question. Let's say there's a patient with amino aciduria. Amino aciduria simply means amino acids are appearing in the urine. What does this imply about the amino acid line on this graph? As you recall from the first lecture on the nephron, all amino acids should be reabsorbed in the proximal convoluted tubule. So if there's amino aciduria, that means the proximal convoluted tubule is not able to reabsorb amino acids the way it should, and more amino acids will be excreted as waste. With decreased reabsorption of amino acids, the tubular filtrate concentration will increase. Therefore, the tubular filtrate to plasma concentration ratio will increase. So the amino acid line right here will actually shift up, moving more closely to the bicarb line. Let's do one last question. Let's say you find that the patient has a tubular filtrate to plasma concentration ratio of 1.7. Would this more closely resemble bicarb down here or PaH up here? Well, if the ratio is greater than 1, that is to say there is a greater concentration of plasma, then this would more closely resemble something that is actively secreted, such as PaH. Or you could simply look at the y-axis and see that 1.7 is high on the graph, and you can see that 1.7 is clearly much closer to PaH than to bicarb. Now let's move on to what happens to these solutes throughout the rest of the nephron, starting with sodium. So 65% of sodium will be reabsorbed in the proximal tubules using sodium symporters, and 25% is reabsorbed in the thick ascending limb with the sodium-potassium chloride symporters, and 10% is reabsorbed in the distal tubule and the collecting duct. When talking about the distal tubule functions, it's best to discuss the early versus late distal tubule. The late distal tubule behaves more like the collecting duct. We'll just write CD for short. In the early distal tubule, sodium is reabsorbed via sodium chloride symporters. In the late distal tubule and the collecting duct, sodium is reabsorbed via sodium-potassium pumps and sodium channels. Now let's draw this out and do some questions. Okay, so here's the nephron. I will label the parts here, the proximal convoluted tubule, the loop of Henle, let's write loop, the distal convoluted tubule up here, and finally the collecting duct, and I'll just write CD. So sodium is freely filtered by the glomerulus, and then 65% is reabsorbed by the proximal convoluted tubule via the sodium symporters, such as the sodium glucose symporter and the sodium amino acid symporter. And then in the thick ascending limb, which we'll write right here, 25% of the sodium is reabsorbed via the sodium potassium chloride cotransporter. The remaining 10% is reabsorbed via the sodium chloride symporter in the distal convoluted tubule, so of course bringing in sodium and chloride, and the sodium potassium antiporter in the collecting duct, which brings in sodium and secretes potassium. So whatever doesn't get reabsorbed is secreted into the urine. And under normal circumstances, less than 1% is actually excreted in the urine, which brings up our last point. The last point we will make about sodium reabsorption is the FeNA. The fractional excretion of sodium, or FeNA, is helpful in diagnosing the cause of the patient's renal problem. If it is high, it implies renal dysfunction. So let's first look at FeNA conceptually. So it is the amount of sodium excreted divided by the amount of sodium filtered. So this is equal to the FeNA. So if more is excreted, an increase in FeNA, then less is being reabsorbed. If less is being reabsorbed, then the tubules of the nephron are not performing their functions properly. So let's apply this by doing an example. So let's put up our equation here. So FeNA is the sodium excreted over the sodium filtered. So what is excreted is down here, and that is then divided by the amount filtered, which is up here in the Bowman space. So let's do a practice question. Let's say the FeNA is 3% in a patient. What does this tell you about the function of the nephron? First, recall that normal FeNA is less than 1%. If this patient has a FeNA of 3%, so this ratio has then increased. And it's increased by quite a bit. This indicates that they are excreting way more than normal, which implies that less is being reabsorbed by the tubules. So you can see that sodium is not being recovered here, 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 or maybe even here, in any possible location of these. And sodium is being lost in the urine as a result. The point is that the nephron is not functioning properly in this patient with a FeNA of 3%. Now let's talk about potassium. Potassium follows a similar pattern as sodium. Most of it is reabsorbed in the proximal tubule. It's then reabsorbed in the thick ascending limb via the sodium-potassium chloride channels. And the remainder is managed by the collecting duct. And recall from the first lecture on the nephron that principal cells have potassium channels and sodium-potassium pumps that can be upregulated or downregulated depending upon the level of aldosterone in the blood or the level of potassium in the blood. The alpha cells also in the collecting duct, contain a potassium proton exchanger on the luminal surface. And this is quite responsive to serum potassium levels. So let's apply this by drawing it out. So here's the nephron. I will label the parts here: the proximal convoluted tubule, the loop of Henle, so I'll just write loop, of course the thick ascending limb here, the distal convoluted tubule here, and then finally the collecting duct here. So potassium is freely filtered by the glomerulus, and then it is reabsorbed by the proximal convoluted tubule with water through the paracellular space. Then in the thick ascending limb of the loop of Henle, there is the sodium-potassium chloride cotransporter, which of course reabsorbs potassium. The potassium remaining in the urine by this point is managed by the sodium-potassium pump in the principal cells, which secrete potassium and reabsorb sodium, as well as the potassium proton pump in the alpha cells of the collecting duct, which reabsorb potassium and secrete protons. So now let's do some examples. Let's say there is a patient who has muscle cramps, heart arrhythmias, and an EKG which shows a flattened T wave, and you suspect hypokalemia. We'll write hypokalemia. If this patient has hypokalemia, what would you expect to happen to the concentration of potassium in the urine, and why? So we'll just leave our question up there and we'll come back to it. So the potassium that is in the blood will be freely filtered as usual, although less potassium will enter the urine because there was less potassium in the blood to begin with. Of course, so lower potassium here means less here. However, 65% of the filtered potassium will still be reabsorbed here. Then another 35% will be reabsorbed here. And now to the collecting duct. Less potassium will be secreted by the principal cells because there is less potassium in the blood. And I will draw a down arrow here to indicate decreased secretion. And the potassium proton pumps in the alpha cells will begin reabsorbing more potassium. So we'll draw an up arrow here. And this will decrease the urinary concentration of potassium even further. So in a patient with hypokalemia, the potassium concentration in the urine will decrease. Let's do one more example. Let's say there's a patient taking a thiazide diuretic. What will happen to the urinary excretion of potassium in this patient? So we'll write our question up here and we'll come back to that. So as a review, thiazides block the sodium chloride channel in the distal tubule. So we'll draw the sodium chloride channel here, distal tubule, which reabsorbs sodium and chloride, and the thiazide, which we'll write TZD, will block this channel. So the patient is then excreting more sodium and chloride. And recall that water follows sodium. So each molecule of sodium that is lost in the urine means that a proportional amount of water is lost in the urine as well. So this patient is excreting more water, hence the name diuretic. If the patient has lost water, he or she has less fluid in the body, which would stimulate the renin-angiotensin-aldosterone system, increasing levels of aldosterone. So we'll just summarize this. Less water leads to increased renin-angiotensin-aldosterone system activation, which would then lead to increased aldosterone, of course. And recall from the adrenal lectures in the endocrine chapter that increased aldosterone would stimulate this pump here, the sodium-potassium exchanger. And this will increase the secretion of potassium. So we'll draw an up arrow there. Thus, this patient is losing more potassium as a result of taking this thiazide diuretic. So in answer to our question, what effect does thiazide have on potassium excretion? It'll increase it. Now let's talk about chloride. As with sodium, most chloride is reabsorbed in the proximal tubule with water. As water is reabsorbed paracellularly in the proximal tubule, chloride is pulled with it. The rest of the chloride is reabsorbed in the thick ascending limb via the sodium-potassium chloride cotransporter, as well as the sodium chloride symporter in the distal tubule, and the bicarb chloride exchanger in the alpha cells of the collecting duct. We're not going to spend any more time on chloride. In fact, the relevance of chloride levels in the urine are discussed in the acid-base lecture of this chapter. So now let's talk about calcium. Almost all of the calcium is reabsorbed in the proximal tubule and the thick ascending limb. In the proximal tubule, calcium follows water, similar to chloride and potassium. In the thick ascending limb, calcium is reabsorbed as a product of the function of the sodium-potassium chloride cotransporter. Notice that the C in NKCC does not stand for calcium. It stands for chloride. So how then does this pump increase the reabsorption of calcium? As sodium, chloride, and potassium are reabsorbed, more potassium leaks back into the urine, which creates a net positive charge. This creates a gradient that favors the reabsorption of calcium through the paracellular space. And this is discussed in detail in the first lecture on the nephron. The remaining 10% of calcium is reabsorbed in the distal tubule using a sodium-calcium exchanger. Now let's talk about magnesium. So magnesium is reabsorbed in the proximal tubule, the thick ascending limb, and the distal tubule. The percentages are not high yield. The thing to remember is that most of the magnesium is reabsorbed in the thick ascending limb, as you can see, 55%. And this is through the paracellular space. And this is a similar mechanism as the calcium reabsorption in the thick ascending limb, which was discussed in the first lecture on the nephron. So now let's talk about urea. Urea is reabsorbed and secreted in the nephron. So let's start from the beginning. Urea is freely filtered by the glomerulus, and 50% of that is reabsorbed. And this is in the proximal convoluted tubule, and this is done through simple diffusion. And then, in the thin descending limb, urea is secreted back into the urine, which is also done through simple diffusion. Then there is no reabsorption or secretion of urea until the urine finally reaches the medullary collecting duct. Once here, urea can be reabsorbed through facilitated diffusion using the urea transporters in the principal cells. Now let's draw this out. So here's the nephron. I will label the parts here: proximal convoluted tubule, the loop of Henle, I'll just write the loop, thick ascending limb, the distal convoluted tubule, and finally the collecting duct. Let's also draw a line to denote the cortex from the medulla. So here we'll draw a line, we'll draw cortex at the top and medulla at the bottom. So urea is filtered by the glomerulus, and I will just write a U for urea. Then in the proximal tubule, 50% will be reabsorbed. And then moving down the thin descending limb, urea is passively secreted back into the urine. And this is because the thin loop is permeable to urea, and there's a high concentration of urea in the medullary interstitium. So now we have some urea in the urine, and as the urine flows from the thin loop, the tubules are not permeable to urea. So there is no transfer of urea all through here. However, as you reach the medullary collecting duct, not the cortical part of the collecting duct, this is really important. It's the medullary part of the collecting duct that is permeable to urea. So as urine reaches the medullary collecting duct, there are urea transport channels. And it is through these that the urea can be reabsorbed into the interstitium in high quantities. All this urea contributes to the high osmotic gradient in the interstitium, which is so useful for concentrating the urine. And we will talk about concentrating the urine in the next slide, so don't worry a ton about that right now. But notice how the urea is reabsorbed in the medullary collecting duct here, and then it can be secreted back into the thin descending loop, which is permeable to urea. In this sense, urea is recycled in a loop, also known as urea recycling. Now let's talk specifically about how the nephrons of the kidney concentrate and dilute the urine. First, let's get some terms out of the way. The urine or tubular filtrate of a given segment of the nephron is considered isotonic, hypotonic, or hypertonic. This label is determined by comparing the osmolarity of the segment to the osmolarity of the plasma. If the urine osmolarity is equal to the osmolarity of the plasma, it is considered isotonic. If the urine osmolarity is greater than the osmolarity of the plasma, it is considered hypertonic. If the urine osmolarity is less than the osmolarity of the plasma, it is considered hypotonic. The ability of the nephron to concentrate the urine comes from the corticopapillary osmotic gradient. This simply means there is increasing osmolarity as you go deeper into the medulla. And this gradient is created by a few different things. First, there is a high concentration of sodium, chloride, and urea in the interstitium. Together, these solutes provide great power to pull water from the urine. And ADH actually increases sodium chloride reabsorption by upregulating the sodium-potassium chloride pumps in the thick ascending limb. ADH also increases the urea transporters in the medullary collecting duct, which allows urea to be recycled into the interstitium. And we'll go over that in the next slide. As mentioned before, sodium and chloride are reabsorbed in the thick ascending limb of the loop of Henle using the sodium, potassium, and chloride pumps. This sodium enters the interstitium and contributes to the osmolar gradient as mentioned above. But sodium and chloride also enter the vasa recta, the vessels that surround the loop of Henle. This increases the osmolar power of the vasa recta to pull water out of the descending loop of Henle, increasing the concentration of the urine at the bottom of the loop of Henle. This is called countercurrent multiplication, and ADH can actually increase that as well. Now, I'll draw all of this out in great detail and do some practice questions. And just as a side note, this topic is historically among the most difficult and confusing for students, and questions about this topic are among the most frequently missed. However, after going through this section of this video, you will be able to not only understand how this works, but you will be able to answer almost an infinite amount of questions about the topic. So let's dive in. So now let's draw this out. So here's the nephron. And I will also draw a dotted line to distinguish the cortex from the medulla. Draw the cortex up here, medulla down here. We'll draw the glomerulus, the afferent arteriole here, the efferent arteriole here, and we'll draw the peritubular capillaries continuing over here. And recall that these capillaries reabsorb much of the filtered urine from the proximal tubule. The blood supply then continues over here at the ascending limb of the loop of Henle, then it continues around the loop and then up the descending limb. It then crosses over here to supply the distal convoluted tubule, and then finally the collecting duct. And we'll just show it wrapping around the collecting duct. Then it goes to the rest of the body. Now let's take a moment to review the flow of blood versus the flow of urine. So the urine is flowing this way, while the blood is flowing this way. This is counter to the urine. Hence the term countercurrent in the term countercurrent multiplication. We will revisit this topic and apply it in a little bit. Recall that we talked about the corticopapillary osmotic gradient. And that just means as you move from the cortex to the medulla and the medullary pyramids or the papillae, the concentration of electrolytes increases. So in the cortex, the osmolarity is somewhere around 300 milliosmoles per water. We'll just write 300. And towards the bottom, in the medulla, the osmolarity is somewhere between 600 milliosmoles to 1200 milliosmoles. Where the concentration falls in this range depends on the level of ADH in the blood. The osmolarity in the cortex doesn't really change all that much in response to ADH. It's really only the medulla that can increase in osmolarity with the presence of ADH. Now recall that 3 molecules create the osmotic gradient: sodium, chloride, and urea. And I'll just draw a few of these throughout the medulla. Recall that there is some in the cortex, it's just not as significant. So I'll just draw some sodium, chloride, and urea a little bit up through there. It's important to recognize that the interstitium and the plasma will equilibrate to have the same osmolarity. Just draw an equal sign there. So high osmolarity in the interstitium means high osmolarity in the surrounding capillaries. Now let's focus on how sodium and chloride enter the interstitium and the plasma. So here in the thick ascending limb, sodium and chloride will be reabsorbed through the sodium-potassium chloride pumps. And this will increase the osmolarity of the interstitium as well as the osmolarity of the vasa recta right here. This hypertonic blood will then travel around the loop of Henle, which will increase the water that can be reabsorbed from the descending limb of the loop of Henle. So recall from the first lecture on the nephron that water is reabsorbed passively from the descending loop of Henle. And if you have increased osmolarity in the vasa recta and the blood that surrounds the descending loop of Henle, you're going to get more water reabsorption there. And this is where we talk about countercurrent multiplication. This countercurrent increases or multiplies the osmotic power of the interstitium to pull water out of the descending limb. Another way sodium and chloride enter the interstitium is at the distal convoluted tubule. Recall that there are sodium chloride symporters up here. So the sodium and chloride that enter here will contribute to this osmotic gradient. Here's an arrow to indicate the high osmotic gradient. Now let's talk about urea. Recall that through urea transporters in the collecting duct, urea will enter the interstitium. So here, urea is leaving the collecting duct and entering the interstitium. And this, of course, will contribute to the osmotic gradient as well. The whole point of this osmotic gradient is to be able to reabsorb water back into the blood. And this will then concentrate the urine. Now let's summarize what we know about the concentration of urine so far. For this segment of the discussion, we will assume that ADH is low, right? Low ADH. So as the blood is filtered, the proximal tubule will be isotonic. This does not change in the presence of ADH. And that is super high yield to remember. The proximal tubule is isotonic, so around 300 milliosmoles per liter, roughly that of plasma. As the urine descends down the loop of Henle, it gets concentrated, so the concentration at the bottom of the loop of Henle is high. I will draw an up arrow to signify the high osmolarity of the urine and write 600 milliosmoles per liter. So the osmolarity has increased. As recall, we lost water here. As the urine ascends up the loop of Henle, sodium and chloride are removed. And this will dilute the urine a lot. And up to this point, the urine has never been more dilute. So I will just draw a down arrow right here to signify the low osmolarity in the distal tubule. And then I'll write 100 milliosmoles per liter. As you can see, 100 milliosmoles per liter is lower than that of the proximal tubule, which is about 300 milliosmoles per liter. And then again, the proximal convoluted tubule osmolarity is a surrogate for the plasma osmolarity. In other words, the distal tubule is considered hypotonic. Recall that sodium and chloride are then reabsorbed from the distal tubule. Draw that here. And this will further dilute the urine. In fact, with no ADH, as in the case now, the osmolarity at the end of the collecting duct will be even lower than in the distal tubule. Again, this will happen in the presence of low ADH. This is because water cannot be reabsorbed from the collecting duct without ADH. So if you're just continually losing sodium and chloride, but not water, the concentration at the end of the collecting duct will be quite low. So I'll draw a down arrow, and it'll be around 50 milliosmoles per liter. If ADH is present, aquaporins will be available and water can be reabsorbed. And the urine and the collecting duct can be very concentrated. But before we focus on changes with high ADH, let's review the osmolarity in each part of the nephron when ADH is low. The proximal tubule has 300 milliosmoles per liter. The bottom of the loop of Henle is around 600 milliosmoles per liter. The distal tubule is around 100 milliosmoles per liter, and the end of the collecting duct is around 50 milliosmoles per liter. Now let's focus on changes of urine concentration in the presence of high ADH. We just briefly reviewed that ADH increases the reabsorption of water from the collecting duct by upregulating the placement of aquaporins, draw that here, on the surface of the cells. So water can be reabsorbed into the blood. However, ADH can also increase the osmolar gradient in the interstitium. So let's dive into how ADH actually increases this osmolar gradient. First, it upregulates urea transporters. So you can salvage even more urea from the urine. And so you're going to lose even less urea as waste. The second thing ADH does is to upregulate the sodium-potassium chloride pumps. And this happens in the thick ascending limb. And this increases the sodium and chloride that enter the interstitium, thus further increasing the osmotic power of the interstitium. So let's pause for a moment. Because of the actions of ADH, the concentration of urea, chloride, and sodium has increased in the interstitium. Thus, ADH increases the osmotic power of the medullary interstitium to reabsorb water. And as we stated before, if you're reabsorbing more sodium and chloride, more will enter the interstitium and the vasa recta. So you'll be able to increase the countercurrent multiplication. So more water will be reabsorbed from the descending limb. And if you are reabsorbing more water down the loop of Henle, the concentration at the bottom will further increase. And I will draw an up arrow to signify this increase in concentration in the presence of ADH. And I will write 1200. Recall that with low ADH, the concentration here was around 600. So as you can see, the concentration here in the bottom of the loop of Henle practically doubled in the presence of ADH. Now the question is, how does the osmolarity of the distal tubule change in the presence of ADH? Well, you have increased the reabsorption of sodium chloride from the thick ascending limb, which we just described, and this will further dilute the urine by the time it reaches the distal tubule. So you may think that the distal tubule would have a lower osmolarity than in the presence of low ADH, but this is not the case, and I will explain why. Recall that the urine was even more concentrated at the bottom of the loop of Henle. It went from 600 to 1200 milliosmoles per liter. So the increased reabsorption of the sodium and chloride here from the thick ascending limb really just compensated for the increased concentration just before at the bottom of the loop of Henle. So the osmolarity of the distal tubule did not decrease further than in the presence of low ADH. The point is that the osmolarity of the urine at the beginning of the distal tubule doesn't change a whole lot regardless of the level of ADH. It remains hypotonic or dilute, but it doesn't change much from there. For example, if it was 100 milliosmoles before ADH was present, it will be 100 milliosmoles after ADH is present. As we mentioned before, when ADH is present, the collecting duct becomes more permeable to water. Now keep in mind that not only does ADH allow water to be reabsorbed, but it increased the osmolarity of the interstitium substantially. So water will be highly reabsorbed, and the osmolarity will be quite high. So I will draw an up arrow down here at the bottom of the collecting duct to indicate increased osmolarity and write 1200 milliosmoles per liter. Recall that with low ADH, the concentration here was around 50 osmoles because water could not leave the collecting duct. So the urine in the collecting duct went from being very hypotonic with low ADH to being very hypertonic in the presence of high ADH. Let's review the osmolarity in each part of the nephron when ADH is high. So the proximal tubule has 300 milliosmoles. Again, that doesn't depend on the level of ADH. It's always going to be isotonic regardless of the level of ADH. And the bottom of the loop of Henle is around 1200 milliosmoles, the distal tubule around 100, and the end of the collecting duct around 1200. Now let's do some practice questions to apply what you know. How would a loop diuretic alter the osmolarity of the urine at the bottom of the loop of Henle, the distal tubule, the collecting duct, and the vasa recta? Recall that loop diuretics will block the sodium-potassium chloride pumps in the thick ascending limb. So we'll draw sodium and chloride being reabsorbed here. And so if the loop diuretic blocks this, more sodium and chloride will be excreted as waste, because they will not be reabsorbed. Now, if less sodium and chloride are reabsorbed, the vasa recta will be less concentrated and will therefore be less able to reabsorb water from the descending loop of Henle. So the osmolarity of the countercurrent here will be a little bit lower than normal. And so the water that would be reabsorbed here in the descending limb will not happen at as great of a rate and as powerfully as when there was a lot of sodium chloride floating around in the vasa recta here. And that means that the osmolarity at the bottom of the loop of Henle will also be lower. So we'll draw a down arrow. However, it's still hypertonic. It's just less hypertonic than it was before. So we'll draw less hypertonic. Now, what happens to the osmolarity of the collecting duct? Well, with the loop diuretics blocking the sodium and chloride reabsorption, the osmotic power of the interstitium will significantly decrease. So where you had a lot of osmotic power, without the loop diuretic, you're going to have less osmotic power with the presence of the loop diuretic, because you're just salvaging less sodium and chloride. This means that when ADH adds the aquaporins on the collecting duct, you're not going to reabsorb as much water, because you just don't have the same osmotic power to pull the water back into the blood. Therefore, more water will stay in the collecting duct, thereby decreasing the osmolarity of the urine at this point. And that means that water will be excreted as waste, hence the name diuretic. Now, what happens to the osmolarity of the distal convoluted tubule? So we know that because of the decreased osmolarity of the interstitium, less water will be removed from the descending loop of Henle, so more water will be in the bottom of the loop of Henle and more water will reach the distal tubule. If this was the only factor contributing to the osmolarity of the fluid in the distal convoluted tubule, then the osmolarity would decrease. However, we also know that less sodium and chloride are being reabsorbed by the thick ascending limb, so more sodium and chloride are reaching the distal tubule. If this was the only factor contributing to the osmolarity of the fluid in the distal convoluted tubule, then the osmolarity would increase. The question is then, which is more powerful, the increase in water or the increase of sodium and chloride? With this information, you will actually not be able to answer the question. Again, this is because there are two opposing forces here, and it isn't entirely clear which force dominates under these circumstances. So for step 1 purposes, this is not a fair question. I've included this part about the osmolarity of the distal convoluted tubule just to help you see how a loop diuretic would alter the reabsorption of water in the loop of Henle and the reabsorption of sodium and chloride in the thick ascending limb. In short, it's important to know what a loop diuretic does to the osmolarity of the urine in the collecting duct, the proximal tubule, and the loop of Henle. Now let's do another question. Now, what would happen to the osmolarity at the bottom of the loop of Henle in a patient who is running a marathon? Okay, so if someone is running a marathon, they are losing water. So we'll write decreased water. That's through sweat and things like that. And so the osmolarity of the blood would increase. So we'll write increased serum osmolarity. So in the hypothalamus, the supraoptic nucleus, I'll just write SO for supraoptic, this will sense the increased osmolarity, and then it will increase the production of ADH to be released from the posterior pituitary. So then we'll have increased ADH secretion. And of course, ADH will act on the nephron. And as you recall, ADH will upregulate the sodium and chloride that's reabsorbed from the thick ascending limb. So the osmolarity of the interstitium would increase, but so would the osmolarity of the vasa recta. So we'll draw an up arrow here as well. With increased osmolarity in the vasa recta, more water will be reabsorbed from the descending limb of the loop of Henle. So our question was, what will happen to the loop of Henle osmolarity? With more water being reabsorbed, the tonicity would increase. So let's do one more question. So with very low levels of ADH, which segment of the nephron would have the lowest osmolarity and which would have the highest osmolarity? Okay, so we know that the proximal tubule is isotonic regardless of the level of ADH, so we can assume around 300 milliosmoles per liter. The distal tubule also doesn't change with the level of ADH, so we can assume around 100 milliosmoles. And recall that in the descending limb, regardless of the level of ADH, water will be reabsorbed. However, how much is reabsorbed does depend on the level of ADH. So in this case, with low ADH, we would expect the osmolarity at the bottom of the loop of Henle to be around 600 milliosmoles per liter. So now in the collecting duct, without ADH, no water will be removed. So we'll lose the water as waste. So in this segment, the osmolarity of the urine will be around 50 milliosmoles per liter. So our question was, what segment of the nephron will have the highest and lowest osmolarity? The segment with the lowest osmolarity in the presence of low ADH would be the collecting duct. So we'll write lowest here. And then it'll be the distal tubule, which will be the next most dilute, and then the proximal tubule, which is isotonic to the plasma, and then the bottom of the loop of Henle would have the highest osmolarity in the presence of low ADH. So we'll write highest here. So that concludes our section on the nephron.